Great. Thank you very much for the invitation. You know, Dr. Kapadia, I see him more than just a colleague. He's like a brother. And, you know, we've battled many times in the trenches on difficult patients, so it almost pains me that I'm going to defeat him so handily in this debate. Almost, not quite. So imagine you're 65. You have severe AS. What's important to you? Obviously, you want to know how you're going to do in 3 days. Well, what about how you do in 3 months? What about for the next 30 years? The decisions you make today is going to have an impact on what you're going to be able to do in 30 years. What are your dreams? You want to see your kids have successful careers. You want to see your grandkids grow up. You want to travel the world. Whatever you want to do, you will need to be alive to be able to enjoy those years. So here are the guidelines. Dr. Kapadia showed you the guidelines. And we know that for patients under 65, SAVR has a level 1 recommendation in the 2020. And under 65, there is no recommendation because the studies never studied it in that population. Now, the randomized clinical trials that Dr. Kapadia showed you are all highly cherry-picked patients, right? I'll show you all the exclusion criteria later, but these are highly, highly cherry-picked patients run by an industry with all kinds of bias. What I'm going to show you is what happens in the real world. And what's happening in the real world is that you're taking data from these highly cherry-picked patients and you are generalizing in a generalized population. And the patients that are getting TAVRs today were not the patients that were going into those trials. So let's look at some real-world data, shall we? So Dr. Kapadia in his previous talk showed you that he didn't compile the 2024 data, so I did it for him. So this is the 2024 Cleveland Clinic TAVR data. Fantastic results. Him and his team should be absolutely congratulated. Operative mortality of 0.7, stroke of 0.9, length of stay of 3 days, not 0, not length of stay of 0, but actually 3 days. And there are patients who do go home the same day, but clearly not the average, and readmission rate of 5.7%. Great results. Now, you can't see the surgical data all that well, but let me show it to you. Mortality, 0. Stroke, 0.3. Yes, patients do stay in hospital a little bit longer, but they don't have to come back to the hospital once they're discharged. And maybe we got lucky in 2024, or maybe not. This is what last 3 years look like. All right, operative mortality, all comers, low risk, medium risk, high risk, 0.1% mortality. Stroke rate, 0.3 to 0.5% mortality. So you may say, well, this is just a Cleveland Clinic, right? You know, we do so many surgeries. Each surgeon does over 300 surgeries. And this is not representative of what the rest of the world can achieve in a low-risk population. The surgical risk is much higher. So let's look at what's happening in California. This is the California Health Database. All right, so many different hospitals, some large, some small. And 60 years and younger, patients that were never studied in those randomized clinical trials that Dr. Kapadia showed you. And what was happening to those patients? Half of those patients by 2021 were getting TAVR, off-label. These patients were never studied. These patients were never in the guidelines. And yet, half of those patients were getting TAVRs. Nowadays, probably even higher percentage of those patients. Simply, if a patient is asking for it and the provider is willing to do it, then that's what the patient gets done. And is that the right thing? I would argue it's not, because look at what's happening. All right, SAVR mortality in this group of patients is 0.2%. This is not Cleveland Clinic data. This is all hospitals in California. TAVR is 0.4. But look at what's happening 5 years. SAVR 5-year survival is 98.4%. TAVR 5-year survival in a low-risk, under 60-year-old population is 86%. Essentially, 1 in 8 of these patients are dying at 5 years if they got TAVR first. All right, it is absolutely clear that younger patients, healthier patients, should not be getting TAVR first. And much of that mortality is because of the need for subsequent procedures. Okay, let's move on. So when you interpret these clinical trials, when you're interpreting data, you always got to look at what's happening long-term. Short-term data, 6 months, 1 year, 2 years, doesn't show the whole story. And much of the guidelines is based on short-term data. And when you're also looking at the mortality, any studies in the low-risk population that shows an AVR mortality greater than 0.5% should be met with skepticism. And we all know that STS for low-risk patients overestimates the mortality, and in high-risk patients underestimate the mortality. So you can have a low-risk population, STS 4%, TAVR shows, our mortality is 2%, hence we must be better. It's not true. Surgery in that group of patients should have a mortality of less than 0.5%. So now let's look at what are the mid and long-term outcomes, since that's what we're really interested in, what is happening to these patients. This is a most recent patient. Dr. Kapadia referred to this. This is real-world, risk-adjusted, real-world data, not cherry-picked patients, but what is actually happening. Of course, TAVR is going to be less invasive, and so you're going to have a better early outcome associated with it. But in a low-risk patient, the survival curves are crossing at 9 months. Intermediate risk, the survival curves are crossing at 2 years. Even in the high-risk patients, where you would think that TAVR has the greatest amount of benefit. It is true early on, these patients do survive more with TAVR, but at 2 years, the survival curves are again crossing. Same is shown in Europe. At 10 years, survival for a SAVR, if you got a SAVR, is double than what it would have been for a TAVR, and same is true for Japan, where the 5-year mortality for SAVR is 1.3% versus TAVR is 19%. All right, you can't even compare. These are, these are not even in the same ballpark. And when you look at MACE, TAVR MACE is twice what's higher than SAVR. So now, we know that most of the patients that come for procedures, it's not just the aortic valve. Often they have other comorbidities. Now let's say what happens if you have coronary disease. Well, Dr. Kapadia will tell you, we could do a PCI at the same time. You don't have to have a mammary takedown. You don't need to have vein harvest. We could just do everything from the single 4 punctures. Well, if you have coronary disease, procedurally, yes, there may be an early advantage, but again, the curves are crossing at 1 year. Long term, beyond 1 year, your survival is far better with a SAVR plus a CABG than a TAVR with a PCI. Particularly, that difference is even more pronounced if you had a mammary at the time of your procedure. So bicuspid valve. I mean, look at this valve. Can you imagine putting something in and just spraying all that junk and calcium and rocks and it's spewing around? I mean, you're not taking that out. You're just leaving it in place. And think of not just under the procedure where it's going to go to, but this is going to continue to flake off over time. And that's what some of the long-term outcomes are going to be. So in bicuspid valve, again, this is a very large trial that from the Medicare database, risk-adjusted, SAVR outperforms TAVR long-term. Beyond 1 year, the curves start to shift. What about patients in cardiogenic shock? Now, surely this is a group of patients where you expect the most benefit for TAVR over SAVR. Well, maybe not so. Nowadays, when we have patients that are unstable coming for surgical aortic valve replacement, often we can support them with temporary mechanical support like an Impella device. And at Cleveland Clinic, when you come in with the EF of less than 30% undergoing cardiac surgery, your mortality is 1.4%. That is our outcomes at the Cleveland Clinic. And in fact, if you look at this trial, when they ran, this is the National Inpatient Database, when they did a propensity matching between TAVR and SAVR in patients in shock, the mortality is no different. It's high in both groups, it's 15%, and most of the complications are the same. However, the readmission rates are less with SAVR than with TAVR. And again, this is a national inpatient database, so we don't have long-term follow-up for this. But even in shock patients, you're not seeing a difference. So now you had your first surgery. We're talking about lifelong management. What happens to your next surgery? So redo SAVR versus a TAVR explant are two completely different operations. If you look at the STS database, TAVR explant have a much higher need for concomitant surgery. The incidence of severe MR is much higher. TAVR explants have much more endocarditis. The need for an emergency operation is 66%, when it comes to a patient that's requiring TAVR explant, and a lot more of the TAVR patients need root surgeries, and the mortality is 17% for a TAVR explant compared to a redo SAVR. And when you look at the patients that had concomitant disease, you know that patient that came in with severe AS and moderate MR, and that moderate MR will probably go away with a TAVR? Well, it doesn't really go away. And 5 years later, when you got to come in back and now do double valve, take out the TAVR and do double valve, your mortality is 26%. It's even higher. And the more valves that you got to treat, the higher your mortality is going to be at the subsequent surgeries. So redo SAVR versus valve in valve. I mean, this is the poster child for valve in valve, right? When you do get a SAVR first, and down the road you get a TAVR. This is what we're all promoting to patients. But now let's see what's actually happening to these patients long term. Again, the survival curves are changing. At 2 years for lower risk patients who are getting valve in valve, they do better early, but beyond 2 years, they're better off getting a SAVR, getting a redo SAVR. And in medium and high risk, there's not even a short-term benefit when you're doing valve in valve. Well, how about the third valve, right? We've talked about what to do when you've done your first surgery, second surgery. Now what happens if you need a third surgery? There's a registry right now going on it's called the Third Multicenter Registry, and it is looking at the durability of these procedures and looking at how long each of these strategies get you out, right? If you are a Formula One fan, you know that one of the most important things about winning a race is managing your tires. You have 3 types of tires. You have the red tires, which are thin rubber. It goes faster, but it's not quite as durable. And you got the white tires on the other end, which are much more durable, but they go slower. So this is the same thing. If you're choosing TAVR, you're getting a less durable procedure. Look at the first surgery, TAVR. The durability is only about 5 years, right? And if you get TAVR, that only gets you 7 years out, right, to the third surgery. Versus if you're getting 3 SAVRs, you're getting almost twice as much durability out of it. So who are the patients better served with SAVR? Now, these are all the exclusion trials, and these are all the exclusion criteria in all those trials that were randomized. And this is, unfortunately, not what's happening in the real world. In the real world, patients with these contraindications are actually being offered TAVR. I'm not going to go through the list because there's just too many to mention, and I'm starting to run out of time. Now, what are the contraindications to SAVR? Clearly, if you are somebody who has prohibitive risk, you are on dialysis, you have cirrhosis, your life expectancy is less than 10 years, like Mick Jagger, you're probably better off getting a TAVR first. But even if you have a failed SAVR, now 10 years out, you're probably still better off getting a redo SAVR over a TAVR if your life expectancy is still going to be high. And even low EF patients should not be in contraindications because we've shown and we've published our outcomes on how you could get those patients through with very low risk. Now, during surgery, what else can we do? We could do Ross procedures, we can do mechanical valves, we can do Osaki's, we could do root enlargements, we could do bypasses. All these adjuncts or different surgeries, we have many, many other options when we're doing surgery. So I'm just going to skip this patient prosthesis mismatch data because it's how Dr. Umania has already shown you. But in conclusion, this is what the real life is showing us. The randomized clinical trials cherry-pick patients, but in real life, what we're seeing is in low-risk patients, within 2 years, SAVR's coming out ahead in terms of mortality. Beyond 2 years, SAVR's coming out ahead. In medium and high risk, there's an early advantage with TAVR, but beyond 2 risk, survival curves with SAVR is better. If you have CAD, SAVR is better in short and long term. When you have bicuspid valves, SAVR, again, better long-term and short-term. We're not talking about KCCQE, we're talking about survival. Redo SAVR versus valve in valve. Again, after 2 years, everything on the right beyond 2 years are better off getting a SAVR. And clearly, a TAVR explant versus redo SAVR, you're better off having a SAVR. So fundamentally, this is the two differences that we're seeing, right? This is what you're doing with TAVR. You're just pushing all the garbage aside. Over time, that garbage is going to slowly collect back into the trail, and this is why it's not durable. But look at the beautiful road, the sun with the setting sun and the ocean on the right. That's what you're getting with the SAVR. So again, let me ask you the question: what is more important to you? How you doing in 3 days, in 3 months, or the next 30 years? So it's like buying a house, right? You go to your cardiologist, and he's selling you this beautiful vision. You have this beautiful house on the beach. You wake up 3 days later, this is the ocean that you're looking at. Life is good. You're really happy. 3 months, everything is still good. But now, every hurricane season that comes by, just like your yearly echo, you get a little bit of worry. Well, my grading's a little higher now. And every year, you get the sense, am I still happy with my initial purchase? Or is this what's going to happen to my house? The grading's a little bit higher. It's a little bit higher. It's a little bit higher. And now I have aortic stenosis again. And now, everything that you've worked for, all your dreams, are now shattered. Versus in SAVR, you are getting a fortress that's been around for 1,000 years. And regardless of the weather, the ocean levels, you know it's going to be around for the next 1,000. Thank you very much.